So I'd like to thank Paul and the organizers for inviting me. I'm at Cleveland Clinic now, and I'm currently running the medical operations in Abu Dhabi, Cleveland Clinic Abu Dhabi. But I still maintain very fond affinity for my colleagues at Mayo Clinic and even those who have left, like Paul. And all of this work is based on a tremendous collaboration we've had through the years. I have no disclosures that are financial in origin, but I do have a disclosure that I'm a surgeon, but I'm also spending as much time nowadays inside the cath lab. And I love it that way. And I'll tell you why. We've heard from Dr. Feldman about functional MR, and it's incredible that Dr. Feldman and my perspectives have probably aligned more and more over the last decade. We're doing more and more mitral clips, and that's probably is a good therapy for high-risk functional MR patients. We've heard about asymptomatic degenerative mitral regurgitation patients, and those are not the patients that I'll be speaking about today. I'll be speaking about the patients that Maurice has just introduced, and these are the Class 2A asymptomatic degenerative MR patients. I want to start by setting a little bit of perspective. The vision that we brought when we built our robotic mitral valve repair program, which is quite different than others that sprouted around the world at the same time contemporaneously, and then guide you through the facts. Not just opinion, but published facts about what this technology offers to the Class 2A patient. I want to begin with Dr. Feldman's really visionary work that's translated now around the world into the huge explosion of mitral clip therapy. This is really remarkable. And I like this slide because the takeoff of the mitral clip really occurred at about the same time that we were thinking about developing a robotic mitral valve repair program. And what's interesting is that they've evolved along two nice pathways. There's nice evidence supporting their use in the populations that they've been utilized in, and particularly with functional MR and high-risk degenerative. This is a very, very useful therapy that we utilize quite avidly. But let's start with a little perspective on degenerative MR, particularly the Class 2A patient. So the vision a decade ago when that mitral clip curve began was as follows. We sought to create a less invasive alternative to sternotomy or thoracotomy, by the way, delivering, however, the proven outcomes of traditional degenerative mitral valve repair. And you all know from the prior slides the enviable outcomes of that operation over the past several decades. To deliver the proven outcomes of traditional mitral repair while optimizing value for patients and payers. Now, that's an odd statement to put into a surgical lecture, but let me just take a step back and show you how we measure value at the Cleveland Clinic. It's an amalgam of quality, safety, and patient experience over cost to derive a unit known as value. And this, if many of us haven't been used to this concept, many of us are going to be familiar with it very, very soon, because U.S. healthcare is undergoing a massive transformation that will put value, and in particular the cycle of care through integrated practice networks at front and center in everything we do in every healthcare organization across the nation. So what I'll do at this point is turn our attention to the topic of the lecture, which is robotic mitral valve repair for the 2A degenerative mitral valve regurgitation patients. And I'm going to take you through 8 reasons, simple reasons, showing one paper in each bullet point, in each number, why your patients need access to high quality robotic mitral valve repair. Number 1, it emulates the open operation. There simply is no technique that can be performed via sternotomy, degenerative mitral valve repair, that cannot be performed with robotics. And in fact, it's quite the opposite. For those of us who do a lot of this, it's actually harder to place cords exactly where we want in a closed chest milieu. And this is one of the first papers to really, out of the gates, and my colleagues at the Cleveland Clinic at the time, show that degenerative mitral valve repair performed robotically, in this case for posterior leaflet prolapse, was as good as open repair. And Tom Mihailovich and Mark Ilanoff and colleagues concluded that robotic repair of posterior mitral leaflet prolapse is as effective as conventional approaches. Technical complexity and longer operative times a decade ago for robotic repair are compensated by lesser invasiveness and a shorter hospital stay. And that's evolved, and I'll show you why and how. Number 2, this is an eminently safe operation, given that appropriate constraints are put into place. And in our view, that is a CT angiogram of the chest, abdomen, pelvis to image not only the chest, but the peripheral vasculature to ensure that peripheral cannulation is possible, retrograde perfusion is safe, and there's no significant calcification in the myocardium. And this is one of our first propensity matched analyses from Mayo Clinic data, looking at open and robotic patients done contemporaneously over the same period by the same surgeons. And we showed that not only were complications lower than had been reported previously, but there was no statistically significant difference between degenerative mitral regurgitation patients undergoing repair via sternotomy or robotically. We published results in our first 100 series in Mayo Clinic proceedings, concluding that robotic-assisted mitral valve repair using proven conventional open repair techniques is reproducible, safe, and hastens recovery for all categories of leaflet prolapse. Fact number 3, many worried that robotic repair would remain in the realm of posterior leaflet prolapse, and that simply wasn't true. We sought to duplicate the exact techniques that we utilized via sternotomy in the closed chest environment, and we found that the same proportions of patients who were undergoing repair via open sternotomy were being repaired robotically. So in other words, we did not select candidates for robotic repair based on complexity of prolapse or severity of regurgitation, but rather on the appropriateness base ascertained by a three-dimensional a CT angiogram of the chest, abdomen, and pelvis. We concluded in that first report of the propensity matched analysis that robotic mitral valve repair allows complete anatomic correction of all categories of leaflet prolapse utilizing techniques identical to open approaches. Fact number 4. Over the last decade, we've sought to prove in a reproducible and stepwise manner that equivalent quality could be obtained utilizing this approach. We, in a recent circulation paper that looked at our first 500 robotic mitral valve repairs, we studied those that came back for echoes at 30 days and 1 year. Now, let me take a sidestep for a second. In setting up this program, I had a personal mandate to ensure that we were doing no harm to these patients. So I asked each patient to come back for echoes at 30 days, 1 year, and yearly thereafter. Some of my colleagues in the echo lab thought I was crazy and I was giving them more work, but and Paul was part of that era, but they complied thankfully, and we had a very high rate of return of these patients. But what happened after they came back typically for their 1 year echo, as many of you know, when a patient is well asymptomatic and has no recurrent MR, they stop coming back after a while. But nonetheless, we're gratified to show, we're appreciative that we weren't doing no harm and that these patients had stable repairs over time, not only 30 days, 1 year, but continuing thereafter. And this translates to a very high overall survival and a high freedom for mitral reoperation. Fact number 5, we didn't just sit back and say, okay, we're at the pinnacle of our performance in robotics. We've actually sought to continuously improve. So not only are the prolapse categories similarly complex between open and robotic platforms, but our times have decreased. Cross-clamp times are now well less than an hour. Surgery times, skin to skin, in the 3 to 3.5 hour range. Most patients, are extubated on the table and go to the floor the same day of surgery, and reproducibly, hospital stay has been a short 3 days. And this has not only been at Mayo, but it's been at Cleveland and now in Cleveland Clinic, Abu Dhabi. Fact number 6, concomitant procedures are permitted and actually facilitated, whether it be a maze, as has been shown by Randy Chitwood in his paper, or concomitant functional tricuspid regurgitation repair. Fact number 7, there's enhanced patient experience. Many wondered whether this was just a gimmick. As you can see with this lady actually flew from Colorado in her private jet. She was able to avoid removal of her breast implant and undergo complex anterior leaflet mitral valve repair utilizing robotics. We showed that time to return to work was quicker following a robotic approach, and early quality of life was similar to open repair by 3 months, but early on, robotic repair had an enhanced early quality of life. Fact number 8, to finish this off, and as I spoke about at the beginning of this lecture, it's all about the denominator, with the numerator being safety, quality, patient experience per unit of cost. The cost has not been studied extensively, but we're doing this now not only in MitraClip, but Cardioband and now robotically. As my colleagues from Cleveland Clinic showed, the higher operative cost was offset by lower postoperative cost and earlier return to work. And by a volume of 100 or so patients, these costs overlap with conventional approaches. We showed the same in our report from Mayo Clinic. So in conclusion, we cannot ignore the need for change. The field has dramatically evolved over the past decade. We speak daily about this coefficient of safety, quality, and patient experience over cost to derive a unit of value. Remember, this is the same operation. It's safe. It allows complete repair, high quality. It's continuously improving. It allows concomitant procedures, augments patient experience, and is cost efficient. Thanks very much.